Good evening students. So in this video we are going to discuss about the mechanism of reabsorption of solutes from the thick ascending limb of loop of Henle and its clinical significance in Barter syndrome. Right? For understanding, first of all we will draw a cell of thick ascending limb of loop of Henle and try to understand what's exactly going on inside. Right? So let's first of all draw a cell of thick ascending limb of loop of Henle. Right? Right, just like in previous videos we have got a basolateral side and we have got a luminal side. Right, luminal side means on this side we have got the filtrate, right, which will ultimately become urine. On this side we have got blood vessels. Right, now, just like every time, our story will start with our main hero. Who is our main hero? Sodium potassium pump. Right? It will pump sodium outside and pump potassium inside. Right? What it will lead to? It will lead to reduction of sodium inside the cell. Right? So this is going to create a gradient. Since we have got less sodium inside and we have got normal sodium outside, so there will be gradient. Right? Now, which ion channel will use this gradient? We have got one sodium, right? One potassium and two chloride channel over here. Right? So up till now the story is simple. We have got sodium potassium pump, which is pumping sodium outside, pumping potassium inside, which reduces the level of sodium inside, and now sodium has got gradient, right? And potassium or chloride are using that gradient to get transported inside, right? Now this chloride which has entered inside has to escape out, right? So it will escape out through potassium chloride symporter. Right? Over here we have got potassium chloride symporter. Right? It will also escape out through one very important ion channel. Right? This chloride channel is called CICKB or Barton. Very important. It's also called Barton. Right? In one of the types of Barter syndrome, there is mutation inside the Barton chloride channel. Right? Now this potassium which has come inside, right, this will also escape. It will escape through the potassium chloride symporter, right, and it will also escape through ROMK, right, ROMK ion channel. Right? So up till now the story is simple. These two chloride ion channels, right, this will escape through potassium chloride symporter and Barton chloride channel, and this potassium will escape through potassium chloride symporter and through ROMK channel. Right? So up till now everything is crystal clear. Now, which drugs, now this is of utmost clinical importance, right? Which drug actually act on your thick ascending limb of loop of Henle? It's a very important drug, right? We call this class of drug as loop diuretics, right? Most famous example of this thing is Lasix, right? And the generic name is furosemide, right? So furosemide act on this one sodium, one potassium, two chloride ion channel, right? Furosemide. It's going to block this channel, right? Now it's obvious, if furosemide blocks this channel, then what is going to happen? You will have lot more accumulation of sodium potassium, chlorine on this side. Sodium, potassium, chlorine will get accumulated over here. And wherever sodium goes, the water follows, right? So you will end up excreting lot more urine, right? Since lot more sodium is here, lot more water will follow and lot more urine will be excreted out. So furosemide serves its purpose, right? That's why it's given in congestive heart failure, right? And it's also given for managing hypertension, right? So what it will lead to? Of course, you can guess that it will lead to natriuresis and kaliuresis. Natriuresis and kaliuresis. Right? Sodium will be also excreted out and potassium will be also excreted out. And this is also a very important clinical point, that in case of chronic furosemide therapy, right, you have to supplement the patient with potassium salts, right? Because apart from sodium, you are also losing potassium in it, right? And we also give that potassium sparing diuretics. The mechanism we will discuss in another video, but in this video you can see that yes, as soon as this thing is blocked, right, both sodium and potassium are excreted out, natriuresis and kaliuresis. And briefly we are also going to discuss how Barter syndrome affects. Now there are many varieties of Barter syndrome, right, but we will briefly discuss how Barter syndrome affects the ion channels over here, right? Let's write Barter syndrome somewhere. Barter syndrome. Right? Now if Barter syndrome comes over here, it's going to, this channel becomes defective in Barter syndrome, then of course you can guess what is going to happen. The whole of sodium will be excreted out, the potassium will be excreted out. So what we are going to see, if Barter syndrome affects this channel, we will see hyponatremia, right? Right? And apart from that, since the potassium is also being excreted out, we will see hypokalemia. Right? Now one very important point over here, this thing is getting blocked. We will have lot more sodium and lot more potassium trying to go outside, outside into the urine via passing through DCT and collecting duct, right? Now this collecting duct has got an ion channel. I'll draw a small collecting duct over here for you. This collecting duct would like to preserve this potassium. Potassium is very precious for the body. So collecting duct will try to preserve the potassium, right? And what it will try to do, that it will reabsorb potassium, but in exchange it has to excrete out H plus ion. It will reabsorb potassium, but in exchange it has to excrete out one H plus ion, H plus K plus exchanger, right? So what it will lead to is that in the process of trying to preserve potassium, it will end up excreting H plus ion. So this will lead to alkalosis, right? So you will have hyponatremia, hypokalemia and alkalosis, right? Right? And because of hyponatremia, you will also have hypotension. I'll make a separate video on Barter syndrome, but here we are discussing it briefly, that what actually the Barter syndrome can lead to, right? Apart from that, Barter syndrome can also affect this Barton chloride channel, right? When Barter syndrome affects this Barton chloride channel, now main thing with this channel is that this channel is also found in stria vascularis of inner ear, right? So apart from defect in reabsorption of solutes in loop of Henle, this is also found in stria vascularis of inner ear. So what it will lead to? It will lead to deafness. So in certain varieties of Barter syndrome, you also have deafness. Right? Okay? So hopefully whatever I have described is clear, right? If we try to sum it up briefly, right? You have got one sodium, potassium, ATPase, which is running the whole show, right? It is pumping sodium outside and pumping potassium inside. This creates less sodium inside the cell. This gradient is used by one sodium, one potassium, two chloride ion channel, right? This chloride will escape through potassium chloride syn-Porter and also through one very clinically very important channel called chlorine CICKB Barter channels, right? This potassium coming inside will escape through potassium chloride syn-Porter and ROMK ion channels, right? The furosemide, by acting on one sodium, one potassium, two chloride channel, will cause natriuresis and kaliuresis, right? Barter syndrome, if it affects one sodium, one potassium, two chloride channel, will lead to hyponatremia, hypokalemia, right? And this excess potassium which is going outside, the collecting duct will try to save that potassium but will end up excreting H plus ion. So it will lead to alkalosis. If the Barter syndrome affects your chlorine CICKB channel, these chloride channels are also present in stria vascularis of inner ear, which can lead to deafness, right? So hopefully this video help you in understanding the mechanism of reabsorption of solutes in the thick ascending limb of loop of Henle, and also in brief about the mechanism of Barter syndrome. Wish you all the very best. Thank you.